Welcome to this edition of Clinical Clips, an accredited continuing education activity. This brief expert video will spotlight the daily hot topics from the conference.
Thanks for joining us on this last of 4 clinical clips from 2023 CROI. My name is Babafemi Taiwo. I'm the Chief of Infectious Diseases at Northwestern University in Chicago. Today we're going to be covering a total of 4 abstracts, starting with the D to F study, which was a study that was conducted in persons who were failing first-line NNRTI containing regimen and were randomized to one of 3 arms, one being boosted darunavir plus 2 nukes, the second arm being boosted darunavir plus dolutegravir, and the third arm being dolutegravir plus TDF and XTC, XTC meaning 3TC or FTC. This is an important study in that it really talks about different options with darunavir and also dolutegravir. The important findings were that, number one, there was non-inferiority shown between the 3 arms. Actually, importantly, the darunavir plus boosted darunavir plus dolutegravir arm actually had met criteria for superiority, and there was a little bit of additional or greater weight gain seen amongst the individuals who were exposed to dolutegravir. Overall, this is an important study because it speaks to some of the characteristics of boosted darunavir plus dolutegravir, which we had not had a lot of information on before. Another study looked at the week 48 data from a study looking at patients who were suppressed on Big TAF FTC and were randomized to continuation of Big TAF FTC or switched to a 2-drug regimen of doravirine plus islatravir. Please note that the dose of islatravir used in that study was 0.75 milligrams, which is not the dose that is now being advanced in clinical development. The dose being advanced has been reduced to 0.25 milligrams of the islatravir. Nevertheless, this study, which enrolled over 600 individuals, is still important because it gives us a hint as to the virologic efficacy of this 2-drug regimen. So at 48 weeks, there was non-inferiority seen in terms of the likelihood of viral rebound to 50 or higher, or maintenance of viral suppression. In fact, virologic rebound was very uncommon in the study as a whole, and the one individual who had virologic rebound on doravirine plus islatravir actually did not develop any resistance to any of the drugs, which is important. The other observation was that lymphocyte count and CD4 count were lower amongst the patients who were given the islatravir containing regimen. But it was a modest decline that was seen, and there was no increase in infections as a result. Other adverse events were overall comparable. Again, important to note that although this has shown promise, the dose that is being advanced in clinical development is a single. It's a regimen of doravirine dosed at 100 milligrams plus islatravir at 0.25 milligrams once a day. The next study looked at thigh injections in patients who are on cabotegravir rilpivirine. Of course, we know that the administration of rilpivirine now is done in the gluteal area, specifically into the gluteus medius muscle. But there were some data presented earlier on suggested that the thigh might be another intramuscular location where the injections can be administered. So this study looked at individuals who were in the Atlas 2M study and had received injection in the gluteal area for 3 years, or in some cases more than 3 years, and now they switched to injections in the thigh. And the results were quite impressive in that the drug levels were maintained. Adequate drug levels were maintained with injections into the thigh as opposed to the gluteal area. And in fact, adverse events were also comparable, being primarily pain that was usually mild to moderate and was rarely treatment limiting. And some patients, about 33% of individuals, expressed the preference for thigh injections, naming or expressing that accessibility and convenience was a major reason why they expressed a preference for thigh injections. So this study suggests that the thigh intramuscular injection of rilpivirine might be an option for some individuals who may be fatigued of getting the injection into their buttocks. And this might be an option to give short-term injection into the thigh instead of the gluteal muscle. And the last study is just a recap that looked at the data from Capella, which is the study looking at lenacapavir, the first-in-class capsid inhibitor, in combination with an optimized background for management of patients who are highly treatment experienced and in virologic failure. It's a phase 2-3 study, and the participants in the study, of course, many of them had resistance to a lot of drugs. And the data presented, we've already seen it at week 52, in that about 78% of the participants actually achieved virologic suppression at 52 weeks, and about 84, with about a mean 84 cells per millimeter cube increase in the CD4 count. So what this study looked at was to dissect it and look at different subgroups to see whether there were subgroups that really did not benefit as much from the intervention. Overall, the results were very encouraging, because when demography was looked at, so looking at age, looking at sex at birth, looking at race, region, etc., the intervention seemed to be effective. And also looking at clinically important parameters such as baseline CD4 count, viral load, and also looking at the optimized background regimen, for example, whether dolutegravir was used or boosted darunavir, or whether abelizumab was used or fostemsavir. Again, the results were encouraging across these different subgroups, pointing to the potential for lenacapavir to help improve the outcomes for our patients who are highly treatment experienced when used in combination with optimized background regimen. So I'd like to close by thanking you for joining us for this final clinical clip. Remember to go to the landing page where you can access the slides and also access several other clinical clips from CROI 2023. Thank you.
We hope you found this activity useful and educational. To receive continuing education credit and to download your printable certificate, please return to the activity webpage and click on the Claim Credit button associated with today's clinical clip.